Well, good morning, good afternoon, or good evening. Who knows when you're watching this? I'm Benjamin Diven, MD. I'm Medical Director for LCFD and 13 other agencies in 3 counties now. But today we're talking about a drug we're going to be introducing here and probably elsewhere as well, acetaminophen. It's a funny thing to be introducing acetaminophen. Who doesn't know what Tylenol is? But this acetaminophen we're going to be giving IV or IO, which is a unique mode of administration. As you all know, acetaminophen is a centrally acting pain reliever whose mechanism is not well understood. It is not an NSAID like ketorolac or Toradol, and it does not have any effect on prostaglandins or inflammation. It is strictly a pain reliever. You do not give it IV or IO for fever. This is strictly for pain management. The indications are mild to severe pain. It's interesting, in head-to-head studies, acetaminophen IV has been favorably compared to fentanyl. There are large studies of services that have abandoned fentanyl in favor of acetaminophen. I'm not ready to go that far, but I'm very curious to see what our experience is going to be with acetaminophen. It is approved in the scope of practice for intermediates and paramedics, so a lot of you will be able to administer this. And for intermediates, this opens up a third pain reliever that you can administer now. The advantages of acetaminophen, supposedly, according to literature, its effectiveness. It's also very, very safe and has a broad range of usefulness. It is toxic in high doses. So the doses that we'll talk about are maximums you don't want to exceed. The dose is 15 milligrams per kilogram, given as a single infusion, and it's not repeated in the pre-hospital setting. It has a long enough half-life that it doesn't need to be repeated, and shouldn't be repeated because of the toxicity. The toxicity relates to the liver. The liver has to metabolize acetaminophen, and it's a very heavy job to do so. So you do not want to give it to people with impaired liver function. That is the big contraindication. That means your bad time chronic alcoholics, your patients with cirrhosis or impaired liver function, your patients who are, interestingly, hypovolemic and may not have good liver perfusion, as well as patients who are in stage 4 or later renal failure, because the final byproduct of acetaminophen is cleared by the kidneys. Now, it's given IV or IO, either one is acceptable. The dose, as I said, is 15 milligrams per kilogram. I am not an expert in med math, and I welcome any of you to review my med math on this and make sure you think I'm in the right ballpark. If you use a 10-drop IV setup, the dosing is 1 drop per second over 15 minutes. It's a 15-minute infusion. At 1 drop per second, you'll administer approximately 1,000 milligrams, which is the maximum single dose, over 15 minutes. It's very easy then to go down to 500, 250, and 125 milligrams by just increasing the time interval between drops in a 10-drop set. 500 milligrams, for example, would be 1 drop every 2 seconds over 15 minutes. You don't want to go faster than 15 minutes, although the side effects tend to be fairly moderate. Dizziness, nausea, and vomiting are the most common infusion reactions, and going faster will aggravate those and produce a metabolic load to the liver that you don't want to get into. There is a toxic side effect, a rash. It is not well described in the literature, so I can't give you the details of it. It appears to start at the injection site and spread, so you need to keep an eye on the injection site for any type of rash and stop the infusion if you see it appear. It comes as a 100 milliliter bag containing 1,000 milligrams. It is pre-mixed, and this makes administration considerably easier than what we've talked about with diltiazem drugs that need to be mixed, like olanzapine. This one can be set up, hooked up to a 10-drop set, and go for the gold. The age limit is 2 years old. Their livers are not well developed below that age, and it can be used up into any adult after that. We've talked about the contraindications, and the indications are really anybody in mild to severe pain that you want to give a parenteral analgesic to. Because it has no drug interactions, acetaminophen can be given along with any of the other drugs we carry in our box. Ketorolac, fentanyl are both compatible. Ketamine is compatible. So you can use more than one drug, which is frequently the case in our patients, where you have to try multiple drugs to get good pain management. We have a good pain management protocol. This will be in there, including the dosing recommendations, so that it'll be simple to keep track of, and the med math should be kept to a minimum. I'll submit it to Hantevi here in the near future so that it'll appear there under the pain management guidelines. It'll just be a new addition to them. And we had questions from the audience that need to be addressed. The first one is, what do you do if someone has already taken acetaminophen or Tylenol orally prior to your arrival? Do you have to reduce the dose? You do if it's been less than 6 hours since the oral dose. An oral dose will be metabolized within 6 hours, and you can give the full dose of acetaminophen, IV or IO. If it's been less than 6 hours, you're going to have to fudge a little bit, and fudge on the low side to try to avoid toxicity. The second question was, since it is compatible with our other analgesics, ketamine, fentanyl, and ketorolac, can the same IV be used to administer those drugs? To my knowledge, there's no reason not to mix them in the same IV. This drug does not crystallize or go kaflooey on you if there are other drugs administered with it. And I think that's the questions that need to be answered. Well, that's it for acetaminophen. I hope this has been brief enough for you to keep your interest. I wish you good hunting out there. I think we'll find this a very valuable addition to our pain regimen. Thank you very much.